Okay, we're going to go ahead and get started. Before I begin introductions to the symposium, I'd like to remind everyone that we have a very brief closing ceremony scheduled to begin immediately after the symposium. There will be a free 2016 ASET meeting registration given to one lucky person who's in the audience. So please stay for the extra 5 minutes at the end of the symposium. Please note that this session is being filmed for a live streaming event. We have asked that you limit entering and leaving the meeting space, stay seated, and refrain from sidebar conversations and other distracting activities. ASET has convened the symposium to address one of the most pressing issues we are facing: how to prevent skin breakdown and injuries related to electrodes. We have an ASET task force that is devoted to collecting information to help us to determine the best practices to prevent skin breakdown. I'd like to introduce the panelists at this time, and each will offer a short introductory presentation from their viewpoint. Our first panelist is Carol Price, RN, MSN, a certified wound specialist, diplomat of the American Professional Wound Care Association. She comes to us from Children's Hospital of Colorado, where she is part of a team investigating injuries related to EEG electrodes. Our second panelist is Sharon Katz, our EEGT manager of the Neurodiagnostic Lab at Montefiore Medical Center in New York City. She is co-chair of the ASET Skin Integrity Task Force. Our third panelist is Brett Netherton, CNM MS, who has written ASET journal articles, given webinars and presentations on the topic of injuries related to electrodes during intraoperative monitoring. Our fourth panelist is also serving on the ASET Skin Integrity Task Force. Cynthia Jenkins works with neonatal and pediatric patients in all children's hospitals in St. Petersburg, Florida. She will be discussing the unique issues related to preventing skin injury in our youngest of patients. And finally, last but not least, I will introduce to you Petra Davidson, our EEGT EPT, who is also a co-chair for the ASET Skin Integrity Task Force. She will be moderating the discussion today. We need to end a little by 4 o'clock, and I just want to invite everybody to stay after for the closing ceremony. Thank you.
I'm Carol Price, and I'm from Denver, or Aurora Children's Hospital, Colorado. And okay, can you hear me now? Okay. And if I can make this clicker work. Oh, there we go. Okay. I'm going to talk about skin care and skin injuries, primarily as they relate to pediatrics, but also some with geriatrics. So the first, I thought I'd just give you a few basic objectives, and basic skin anatomy is the first thing we're going to talk about. Skin assessment tools, which you're probably all familiar with, intervention for preventing pressure injuries, alterations in normal skin, and medical conditions which increase risk of skin injuries and some basic skin injuries. So first of all, the skin is the body's largest organ. 20 square feet, approximately 9 pounds in an adult, and the epidermis, which is the outer layer of your skin, is about 0.1 millimeters. And that varies slightly, and it's a little thicker, as you can imagine, on the soles of your feet, and thinner over areas like the bridge of your nose. So here's a picture of the skin structures. And I'm going to go through each and every one of these, so it'll only take me a little bit of time. I'm not going through all these, but the epidermis is the top layer of skin that, when your skin gets very dry, it's the part you can see flake off. It's also the part when you're doing EEGs and putting the leads on, it's the epidermis that you're exfoliating when you're putting on an EEG lead. And this is just a little more information about that outer layer, the epidermis, and a little bit about the dermis. It's protective, so it keeps protects the body from organisms and from any sort of insults and wounds. In full-term infants, it's about 10 to 20 layers of epidermis. When you have a 30-week infant, there are only 2 to 3 layers of epidermis. And when you get down to the micropreemies, which are around 25 weeks gestation, they have no protective epidermis when they're born. So those babies are so much more at risk. And if you see those babies or work with them, you know that their skin is nearly transparent. You could nearly see through it. And then without the protective layer, you, of course, are at risk for injury and potential infection. In the elderly adults, and that is probably an age range around 85, the outer layer of the epidermis is still there, it's still protective, but when you think about the changes in elderly adult skin, the epidermis flattens and the layers don't decrease, but it becomes more flat, so it's not as protective. And there's less elastin, less connective tissue. There's a decrease in oil production. There's also a decrease in perspiration, so the cooling system of the body is not as effective. There are loss of ridges between the epidermis and the dermis, which is right there. And those ridges help to keep the epidermis and the dermis connected to the subcutaneous layer, or the epidermis connected to the dermis, which then connects to the subcutaneous tissues down here. And without these ridges, the skin is more easily, it more easily has friction and shear that can cause problems and injuries. Blood vessels become thin and fragile as people age. There are medications, Coumadin, any of the blood thinning drugs, those you see people with big bruises or where they have skin tears and a piece of their skin has just sheared off. And then any comorbidities that the elderly get, diabetes, anything with decreased perfusion, and they have decreased healing time, just as a process of aging and their other illnesses. So how do we identify patients who are at risk for skin injuries? We have really 3 different scales that we use dependent upon dependent upon the age of the patient. The Braden scale was the first, and it's for adults, and we usually consider persons over 18 or 21, depending upon the hospital, to be adult and to be assessed with the Braden scale. There is no risk, according to the Braden scale, for skin injury if their number is higher than 18. So the lower the number in the Braden scale, the more at risk the patient is. And then the Braden Q is the pediatric scale. And there's some debate as to what age that should go to. We use it for any child that's in the hospital. So we can use it for kids that are up to 20 years old. But a lot of people say 8 years of age is a cutoff for that, and then you can go to the adult. 8 to 10 years is kind of a cutoff point. There's to be a new Braden scale, Braden Q scale. It was to come out about a year ago, and it was to include medical devices as a category and a prediction, and it has not come out yet. And although we keep hearing about it as wound nurses, we haven't seen it. And then in our neonatal intensive care unit and some of the grad nurseries around, they use the neonatal skin condition score. And that's one of about 3 different scores that are out there for neonatal and premature babies. And there's no risk less than, if it's 4 or less, there's no risk. Above 4, there is risk of skin injury. So for your purposes, you would want to know where this is in the medical record, the electronic medical record, and know whether your patient is at risk or at no risk according to these assessment tools that the nurses use. And the Braden and Braden Q, they look at 6 categories, activity, sensory perception, moisture, friction and shear, nutrition, and tissue perfusion and oxygenation. The lower the score, the more at risk they are for injury. Neonatal skin condition score only looks at 3 categories: dryness, erythema or redness, and skin breakdown. If a newborn or a neonate has skin breakdown, they are at risk regardless of what the other scores are, because they would have a 3, and even if they had 1s on the other ones, they still would be at risk. And dryness is the other important factor to look at with neonates and in your nurseries, because dry skin is more at risk for breakdown than skin that's well moisturized. This is the Braden Q scale, and you can see it's pretty busy and pretty complicated in a way. We're looking this year at whether or not the nurses are doing across the board a similar assessment with their patients so that we have consistency in practice. And the next this is the neonatal score, the neonatal score sheet, if you will. And you can see it's very, very simple in terms of how many categories there are and how the nurses can score that. Then if patients are at risk for pressure ulcers or pressure injuries, this is the Braden Q, and it's for scores between 17 and 22. It's indicating moderate risk for skin breakdown. The probably most important thing on here is movable devices. And so with movable devices, we say they should be moved each shift to reduce pressure on any one area. And devices that cannot be moved should be padded. And we use Mepilex or Duoderm at our hospital. So when you think about EEGs, we know that doesn't happen, probably can't happen, but it is an issue related to skin injury, skin risk. And there's a lot of other things on there, but those are the ones that are most important to what we're talking about today. Then for high risk, it's the same thing. You'll notice, though, reposition devices, it's every 4 hours. So again, when we have a baby or a child that's getting an EEG and it's for 24 to 72 hours, we're violating one of our own rules on movable devices. Not that I'm saying it's possible to move them. I'm just saying that creates a risk when we have kids or even adults that are at risk. We want to move any medical movable device that we can. And then just a little bit about how to clean the skin and pitfalls. This just relates to basic skincare, but you want to avoid harsh cleansers. Alkaline soaps cause drying. Alcohol-based products, gels and cleansers increase drying. And the skin pH is slightly acidic. Somewhere in here I have, we used to say 5.5 to 7. Now, there have been some studies that show it's really probably 4.7 to 5, and that if it's above 5, the skin is not as healthy. The healthier skin is 4.7 to 5. And you should avoid aggressive scrubbing when you're bathing anyone, even yourself, and avoid a dry environment, which in Denver, of course, is kind of hard to do. Now here, it's totally different. So certainly your geographic location makes a difference on that. And then this is preventing skin damage. Use gentle cleansers. This is the 4.7 to 5 for the pH. You want hypoallergenic products. And the people that are producing skincare products for hospitals now all say they're hypoallergenic. That doesn't mean we don't occasionally have some kind of reaction, but for the most part we don't. Fragrance-free, and avoid scrubbing. I liked this little quote: the skin is not a tile floor. The object is not to work up a shine. We're using now at our hospital liquids liquid gels that go in water, and foam, which is a bathing foam. And many hospitals are using bath wipes because there's been some controversy about bath basins that they grow organisms that you really don't want to have around your patients or the hospital. Moisturize after cleansing, gentle cleansers, Cetaphil is one. There's all the products that the major companies that make wound care supplies, they also have a skincare line, and those are different moisturizers and different levels of moisturizers. The one that is not on here is petrolatum. Almost everything you look at is a petrolatum base, which is good because that's Vaseline. It's a oil base. It keeps moisture in. It helps to retain moisture and helps to keep skin smooth. Skin injuries and other wounds. The other wounds that we see in hospitals as wound nurses are incontinent-associated dermatitis. It used to be called diaper rash. Blistering disorders. EB is a very bad disease where they shed their skin. Stevens-Johnson syndrome, another blistering disorder that is a very bad skin disease, and then IV extravasations, which I have on there twice. So those things we're not going to talk about, but that's some of the skin injuries that we see. But what we do see, or what I am going to talk about, is dermatitis. We have allergic or contact dermatitis, skin tears, which results from the lack of connective tissue, and medications or frail blood vessels. You can see that in, of course, the elderly with the frail blood vessels, but you can also see the issues with frail blood vessels, skin that's easily injured in patients who are immunosuppressed. So transplant patients, oncology patients, they have skin that is much more at risk than the average patient would. Skin stripping happens when you take adhesive off, and it takes off at least part of a layer of the epidermis. It can remove epidermis down to dermis. It's usually just a partial thickness wound, never full thickness from adhesive. Pressure injuries and burns and traumatic injuries. So rashes and dermatitis. Contact dermatitis can be chemical. It's from irritants like soap, surfactants that are a kind of soap that are in many of the lotions and things, or the cleansers and things that we use in the hospital. Lanolin can cause contact dermatitis. A lot of people are allergic to that. And an allergic hypersensitivity response. Nickel is very common, especially if you wore earrings, they had nickel, and your ear got infected, then you're probably most likely going to be sensitized to nickel and have a difficult time with it. One of the pictures I saw, and I've seen this happen, is if you have a belt buckle on and it's touching your skin, or a watch band and it's touching your skin, has nickel, you have a nickel sensitivity, you'll get a rash where that belt buckle is, or where your watch is, your watch band. And also gold. I was surprised gold is a metal that people can develop a sensitivity to. Then skin tears, stripping injuries. This is when this dermal connecting layer, here, flattens or doesn't have enough connective tissue with it. And when that happens, that's when you get skin tears. And classically, where I've seen those the most is in the older patient or in the oncology patient, where they just lose a huge piece of skin that gets pushed back, and then you have to manage that as a wound and help it to heal. So fragile skin related to those things is very common. Then pressure ulcer, pressure injury. It's a localized injury to the skin or underlying tissue, usually over a bony prominence, as a result of pressure or pressure in combination with friction and shear. And increased risk factors developing pressure ulcers, for developing pressure ulcers in neonates, children, and the elderly include many disease processes. but primarily those which impair circulation or perfusion, cardiac disease, immobility. We see a lot of paras and quads. We see children with a lot of chronic, medically complex conditions, contractures, just immobility where they can't walk, they're not moving. We also, we see cerebral palsy, kids with CP, we see some MS. Those are all things that can put patients more at risk for pressure injuries. Prolonged periods of respiratory support, the patient's ventilated and sedated, and they don't get moved or turned as much as perhaps they should, or that they would turn or move if they weren't sedated and ventilated. And for our babies, all of these above, plus prematurity. The more preemie the baby is, the more likely they're going to be at risk for pressure injuries. So I'm quickly going to go through the stages of pressure ulcers, not thinking that you're going to know how to stage a pressure ulcer, but that you can describe a skin injury when you see it. So stage 1 pressure ulcers, this is from the NPUAP, which is the national association that created this staging mechanism. And stage 1 is red, non-blanchable, and that means when you push on it, the redness does not go away. So stage 1 pressure ulcer, and it's the first. It can get worse. It generally will get better if you offload the pressure. And those are examples of stage 1 pressure ulcers. This, you can see this, is from a circumferential taping around this baby's limb. And the other one is, it's hard to see with the lights, but there's a redness there that doesn't blanch, and a redness over here. We see quite a bit of that from different kinds of orthopedic devices that children wear to support their ankles and their feet. Then this one I just got today. And this is a red area from an EEG lead, also there, probably also there, but that could be from oxygen tubing. So those are probably stage 1 pressure ulcers. They look to me like the skin's intact, and there's probably one there too. We see a lot of them on the forehead. And then here's another one. This one is red and non-blanchable. It's not open. This one is not quite so red, but maybe a little more purplish red, and might be related, or might be better called a deep tissue injury. Stage 2 pressure ulcer, the most significant finding with that is the skin, the epidermis layer is missing. So I always say if there's open skin and it's pink, it's a stage 2 pressure ulcer. We see some of these related to EEGs, probably not a lot, but again, this is that baby that I got the pictures today, and I think that is probably an open lesion. That looks like a deep tissue injury to me from here. And then these were EEG lead injuries on a patient I saw in the last few months, and they almost look scabbed, and they were originally called stage 2 pressure injuries, and blisters are stage 2 pressure injuries. This may very well have been a blister that dried up, and by the time I saw it, this is what I saw. So they're hard to diagnose, or they're hard to identify the stage on many occasions. And this kiddo had one here too. They almost look like freckles, don't they? These are stage 2 pressure ulcers that you won't ever see. But this is where you've got a pink wound bed and there's no epidermis there. And that's probably almost a stage 3. It's deeper than many stage 2. And this is an open wound here that is a stage 2 pressure injury. Stage 3, they get worse. You're then into subcutaneous fat, tendon or muscle, and they get ugly. There's one there, and here's one under a trach. So those are really hard wounds for us to treat, but we can, and we do. And the stage 4, I took the picture out. It goes to exposed bone, tendon, or muscle. It's very deep. You can feel bone or see bone when you have a stage 4. Then, so it'd be possible to see a stage 4 from an EEG lead, but probably highly unlikely. Although you don't have a lot of tissue here on your head, that you don't have subcutaneous tissue. You have skin, you have muscle, but if you had enough pressure, you could get where you could feel bone. You certainly don't ever want to see that, but it could happen. And again, more likely in the very young or very old. And then deep tissue injuries are skin's intact, they're reddish purple, and they don't blanch, and they often progress to a 2 or a 3, a stage 2 or 3. This is a deep tissue injury on an infant. This is a picture of unstageable pressure ulcer, which can be either like that, or it can be one that is yellow and you can't see the base of the wound. And so here's a yellow one. You can't tell how deep that is, and there's a black one, and here's a black heel, probably a diabetic. This is gangrene, not a pressure injury. But it's pretty classic for gangrene. Pressure injury treatment. What are you going to do to prevent pressure injuries? You're going to offload. So offloading is the key. If you can't offload, you're not going to be able to resolve that pressure injury. I saw a newborn a couple weeks ago. They had a CPAP mask on her, which pushed down right here on her upper lip, caused a pressure injury, and they said, Carol, what should we do? I said, we need to offload that. They said, well, we can't, and they didn't. And within 3 days, it was a stage 3 pressure ulcer, at which point they intubated her, so there was no pressure, and a week later, it was resolved. So offloading is just clearly the key. So if you know someone's at risk for EEG lead pressure injuries or skin injuries, then you need to be really meticulous in how you're putting your leads on and following your procedures. And I would encourage you, if you don't, I'm sure you probably do this, to ask patients and or parents, has the child or have you had an EEG before? Have you had any problems with it? Have you had any skin injuries? Because that's going to give you great insight into what you might want to do differently in your facility and in an effort to prevent anything from happening to the skin. Then move medical devices either once per shift or every 4 hours. We've talked about that. And that's for high-risk patients. It can't be done if you're doing EEGs, but you need to know that that's part of the standard. Then questions. What about EEG leads and isolettes? It's warm, it's humid. How does that affect it? We do see babies who have EEGs in isolettes, and we've seen them with injuries. The length of time, and heat lamps. I think that's probably self-explanatory to all of you, that you put extra heat over a baby, and it's going to have the potential for causing additional injury. Length of time for the EEG, 24 hours, 48 hours, 72 hours. How many do EEGs that are longer than that? Yeah. So, and always with that, the longer, I think the more potential there is for injury. Exfoliating the skin. Remember that in your 30-week infant, there's only 2 to 3 layers of epidermis. So when you're doing exfoliation on babies, you want to be as gentle as you can in that exfoliation, and I think other members of the panel will speak to that more readily than I can. And in the elderly, they have they have the same protective layers, but they've flattened. So because they're flattened, the epidermis is thinning, they don't have elasticity, and they don't have the same connective tissue that a younger person has. So again, they're more at risk of injuries related to EEGs. That's it. Questions? Thank you. Oh. Yes.
So, when the tech identifies that there's an issue with the integrity of the skin, on the electrode removal, or, what do you recommend be the first step?
Go ahead. I'll be fine.
I identify the problem and, tell the nurse.
Right.
That's usually my first step.
Right.
But how can we make sure that?
Our policy says that the nurse and the EEG tech remove the leads. The nurse is there when the leads are removed. So, and they both then look at the skin when the leads have been taken off. So that's what we say is what we do. And I think we do that probably. Where's Cy? I know he's in here. Do you leave? Yeah, 75%. So we don't, maybe not 100%, but that's one way to do it. Have the bedside nurse there with the EEG tech when you're taking off those leads, and both of them can then look at that. Yeah.
On the external if you need.
A whole nother. So who takes off the leads? Right, right. I think in that situation, if you don't have two people to look at it, I think one, just be really clear about your descriptions. And like I said, you don't have to stage it, but you can describe what the skin looks like. And so is it red? I think everyone should know what blanchable is or non-blanchable. To be able to say it's 0.3 centimeters by 0.3 centimeters and zero depth. I always put down a 0 for depth, even if it's obvious that I'm calling it a stage 1. I just want to make sure that everybody knows I looked for open skin. So the length times the width times the depth, which in most cases should be 0, and then a description of what it looks like, or a picture. And pictures have become more and more common in the medical record, and with our electronic medical records. I don't know where ambulatory is with electronic records, but if you have one, and you can put that in there and document, this is what it looked like on the day that they were removed. So that's another slideshow. Yeah.
When the patient leaves after like a few days to stay in the long-term monitoring unit, and they have stage 1 or 2, what's usually the recommendation to tell the patient?
Oh, like what's going to happen to it? I say keep it clean, keep it dry, and leave it open to air unless you're concerned about infection or someone's concerned about infection. You can cover it with a silicone-based adhesive dressing, because I wouldn't want to put an adhesive like a Band-Aid over that, because they could have the same kind of injury or sensitivity to the Band-Aid. So mostly I say clean, dry, and just keep an eye on it. It should get less every day. And if it's not, then I would want them to get in touch with their primary care doctor, wherever they get the follow-up. Okay. Thanks.
First, I hope everybody listened to everything that Carol said, because a lot of my slides are the same, and we'll go through them. I won't show them again. But it's wonderful to hear Carol's presentation, because she has supported or she's at least demonstrated in her presentation, all of the work that this task force has done over the last year. So with that being said, let me just correct the introduction. I'd like this task force to be considered the Skin Safety Task Force. It's about skin safety and then the integrity of the skin as we do it. So let's think of skin safety because that's the issue. So the Skin Safety Task Force was established in May of 2014 as a special committee of the Standards and Practices Committee. ASET had been getting an awful lot of requests or questions from their membership about skin injury, and Faye would direct that to the Standards and Practices Committee, and because there were so many of those questions coming in, Petra and I had a certain passion about this, as well as Lucy Sullivan, who was then our ASET liaison, and Anita Schneider, who was on the committee. And so we were the ones that started to talk about this and investigate it. As a result of this formation of the committee, there was a brief survey that was developed by the committee that was sent to our membership, inquiring if anybody would be interested in participating in a more detailed survey. For those members that responded willingness to participate, a detailed list of questions was prepared. The survey assessed the commonality of skin integrity issues. The survey solicited information on products used, application techniques, length of recording time, and accepted impedance values during long-term monitoring. Unfortunately, the respondents were too few to collect statistically significant data, but and in order to obtain a significant amount of data, an extensive literature search was conducted. There was extensive networking among technologists, which also revealed multiple labs that were focusing on similar issues. A review of the MSDS sheets on a large group of products were reviewed for long-term monitoring EEG. The literature review and networking revealed two very crucial documents in identifying skin breakdown, one by the National Pressure Ulcer Advisory Panel, and the other, University of Florida Health had created what they are calling a flesh scale, and it was, and I'll show you that in a minute, and it was a document that was created so that everybody would speak a common language among the healthcare workers and the team. And it was meant to help track skin breakdown. This is the national pressure thing, and we'll go through those quickly. We're not going to show them. And then John Crawford from the University of Florida has graciously allowed us to share his team's flesh scale cards with you. His team developed this scale in conjunction with the wound care team at the University of Florida Health to develop a common language between technologists and nursing staff. His team offers these cards at no charge to other facilities in hopes that skin breakdown is reduced. So this is his scale. Actually, it's almost identical to what Carol has just presented with a tape so that you can measure wounds and their pictures. So what has the task force learned? Well, we've learned that excessive pressure applied during skin preparation causes skin breakdown. We've learned that a lack of barrier between the electrode and the skin causes breakdown. We've learned that electrodes are considered medical devices. We've never thought of an EEG electrode as a medical device, but they are. And skin can be sensitive to products used. Electrode design can impact skin integrity, and wrapping the head exerts pressure on electrodes. I'm not showing any products, but I'll talk a little bit about the prep, but a comment is, it doesn't matter what product you use or it does matter how you use it, but it really doesn't matter what electrode you use or what product you use. It's the way you use the product and the electrode, and understanding what that relationship to the skin is. And Carol so eloquently alluded to the things that can happen to skin when we maybe don't use the products correctly. So when we prep the skin, there are lots of skin prep solutions on the market, and they have, I'm assuming they're sodium-based. Dave, you can correct me if I'm wrong. Some have more or less of that sodium. That's what makes it that scratchy feel. So if you use that skin prep in excess, if you use a lot of it thinking that you're going to reduce your impedances, and you rub on it, you have now potentially injured the skin. But if you read the directions that the manufacturers put in all the skin preps and electrode creams, lots of them say wipe the prep from the skin, and some of them even tell you that they should not be used in long-term monitoring. Yesterday, Dr. Stecker gave a wonderful presentation on the electrode, and in the perfect world, some of the future electrodes will be the thing that we'll be using. But given our what we have to use now, we need to know how to use it. One of the recommendations is that rather than doing a back and forth or a circular motion to prepare the skin, a unilateral direction is more appropriate. It decreases the amount of abrasion that you exert on the skin. Patients with additional risks, such as neonates and elderly, skin prep can actually be applied with if you take a soft gauze and dip a little bit of skin preparing cream on it, and then just gently put that on there and just massage the area with very little pressure and take it off, you will certainly be able to reduce skin impedance. So this is about learning and trying new techniques and rethinking the way that we've done our electrode application for the last 50-some years. When it comes to electrodes, we've discovered that the flat-rimmed electrodes are the better electrodes. So you all use electrodes, and if you've had an opportunity to visit the vendors this week, they all offer different varieties of electrodes. But those that have a flat rim around the edge are the best, because when that sits on the skin or close to the skin, it does not exert the same kind of pressure as the electrodes that have a more, it's not really a beveled edge, but a rounded edge. So in electrode application, and if your hospital is not using disposable electrodes, it should be something that you should consider, certainly in your ICU monitoring and for long-term monitoring. I know in my hospital, my medical ICU head nurse would not let me do EEG. Well, she threatened to not let me do EEGs in the unit anymore because we were seeing so much skin breakdown, and we were not using disposable electrodes, and we were not using a flat-rimmed electrode. So we have changed that. We've gone to a disposable electrode and a flat-rimmed electrode, and we've seen great improvement in that. So when you're applying the electrode, it's recommended to put a little bit of the conductive paste after you've prepped the area and you've wiped the excess prep off, to put a little bit of that conductive paste on the skin, because it creates a little bit of a barrier. You fill the cup, or even a flat disc if you're using it, with the conductive medium, and then you gently press the electrode into the medium using care to maintain a cushion. You use a small amount of gauze or cotton or whatever you find works for your lab underneath the shaft of the electrode and the tail of the electrode. This protects the injury from the pressure of the shaft and the tail against the skin. And if you are wrapping heads, some labs don't wrap heads in long-term monitoring, but lots of people do, certainly in their epilepsy monitoring units. And you are trying to secure that head wrap, be sure that you do not take the tape when you are trying to secure that head wrap and run it over the front of those electrodes, which adds more pressure. You're going to have to learn to put it up above, but not to put it where it's going to press on the electrodes. And certainly lab protocols should be designed for this. No, I already did that. When you're using a head wrap, use a breathable, soft, stretchy gauze. There are lots of them out there that can really stretch. Ensure that you can slip 2 fingers under that head wrap and pull on that head wrap so that you are exerting less pressure on those electrodes. And again, don't secure that with the tape over the front of the electrodes. One of the things that just go back for a second, one of the things that we learned in our research and review is that lots of us on the committee talked about, well, we do a patch test for the products. But we learned subsequent to that you could sometimes, a patch test can be not very revealing because you don't see any sensitivity or irritation for up to 48 hours. So that isn't necessarily going to be so helpful for you. A really, really important thing is establishing a tracking mechanism. Consideration regarding impedance values, frequency of the site examination, roles and responsibilities of each person on the team should be established. Any evidence of skin change indicates the electrode site should be cleaned and the electrode moved away from the original site, just as Carol was talking about. One of the things that I've learned, and I hope everybody had the opportunity while they were here this week to look at some of the poster presentations. There were 3 posters on skin integrity, skin safety, and among those people that were presenting, it seems that they now have established policies, besides having a great tracking record and coordination between nursing and their EEG team and a bunch of other people, that they're removing electrodes every 3 days, washing the head, and then reapplying. That is labor intensive. So if you're a one-man show and you're doing 1 or 2 long-term monitorings in your ICU, or you have 1 or 2 beds of epilepsy and you're the only one that's doing it, that's very labor intensive. However, these are all practices that have been showing improvement in skin safety. The committee discourages using non-breathable tape on electrodes, certainly the tight head wraps, prolonged recordings over 48 hours with no skin checks, blunt tip needles to reduce applied electrode impedances. I don't know whether anybody is still using that. There is one hospital that has reported they reported the last time we spoke of 700 and some odd days of no skin breakdown on their pediatric epilepsy monitoring unit patients, and they do use collodion applied electrodes, and they are inserting their conductive gel with a blunted needle. It's hard to believe, but I think that they probably have really good training or retraining. So what causes some of the sensitivities in these products that we use? Well, in the conductive creams, there are parabens. We've found that some of the products have a red food dye, some use an egg base, and then the excess that's left on the skin is very irritating. Any skin preparation material left should, between the conductive or electrode at the skin, just just is so irritating. And general hygiene. Our policy at our hospital says that if a patient comes in and their head's not clean and that they should shower and shampoo. Well, I'll tell you, in practicality, that never happens. We do not have the time. The nursing staff does not have the time. So constantly we deal with what we know is right, what we know will help, and then the practicality of enforcing it or implementing it, especially when you don't have the staffing to be able to do it the way you've written it. And that, as I said earlier, the adverse skin reactions may not be seen up to 48 hours. We had, and Carol was talking about the neonates and how sensitive their skin is, and we had done a neonate for many days, a critically ill baby, a preemie, and everything was fine. We finally take the child off monitoring, and the next day we get a call saying that we created this horrible wound. Well, what we have found is that sometimes the wounds are not exterior, but they start internally, and it takes several days for them to actually come to the surface. So as Carol had mentioned, offloading, using these gel packs or the O-rings that you can put under the head. So our hospital has these big silicone, they're almost like pillows that we can put underneath the patient's shoulders and head to keep that head elevated and the pressure off the back of the head.
Can I just interject? No O-rings.
No O-ring?
Pressure in and of themselves.
Oh.
That donut O, and it creates at the occiput a pressure ring around the occiput. So if you're using those old foam donuts, talk to your facility or your skin team about whether or not that's really the appropriate thing to use. What you're talking about are the Z-Flow pillows, which is a brand name, but there are other companies that make them besides that one company. And those will do the offloading. We've had a horrible time getting the round donuts out of the operating room because for some reason it's just tradition.
Thank you. Thank you. No, thank you. And back to the electrodes, the flat rim electrode, the disposable CT, MRI compatible electrodes. You should certainly look into the cost of that. I think in the long term, it's not so cost prohibitive. And a barrier of conductive medium, not so much a foam cushion. The foam, those foam cushions that people use, they are in of themselves irritating to the skin. So it's better to be using something soft like a cotton or a gauze. We actually are using the cotton wrap that they put under casts, plaster casts. And what is nice about using something like that, if a patient is diaphoretic or they're sweating a lot or the conditions in the room especially too hot and they're sweating, that absorbs that moisture and keeps the recording better and the electrode from injuring the skin a lot better. And like I said, cushion the shaft, the tail and the shaft. The one other thing, and just let me go back to electrodes. There are so many electrodes on the market, and everybody will use what they use, what they're comfortable with. There have been reports with gold plated electrodes in the neonatal intensive care unit close to heat lamps that there have been burns. So not gold plated with the alloys, not the gold. Gold, we're told, is less sensitive to the heat. So you need to think about that when you're purchasing electrodes. And so what are the positive and negative outcomes for some of the things that we've looked at? So over preparation of the skin, negative outcomes. Any skin prep solution left on the skin can be a negative outcome. No barrier between the skin and electrode surface could have a negative outcome. Blunted needles may have a negative outcome. Keeping the patient well hydrated is a positive. Room air can be positive or negative. If the room is way too dry, It can cause the skin to be dry, and if the patient isn't well hydrated, well then you may see changes on the skin. Frequent manipulation of the skin, and what I mean by that is electrodes on, electrodes off, electrodes on, electrodes off. Depending on how you secure your electrode to the skin, can result in shearing of the skin. So forget the O-ring, and in fact, we can't even get them, but a silicone or gel pack is certainly a positive. And a tracking protocol. Your departments need to establish a tracking protocol, because if you don't have that, you don't know what you're doing right, you don't know what you're doing wrong, you just know it's not working. And collaboration with nursing and wound care, they are your best friends or your worst enemies. So you have to decide on what side of the team you want to be. And all of you will have resources in the hospitals that you work. Nursing, wound care, infectious disease. Most hospitals have skin safety committees. I've just gotten involved in that in my hospital. There is an organization, Solutions for Patient Safety. It's a pediatric hospital consortium, actually, that there are about 80 facilities that are involved in this. I didn't know it. My hospital was part of it. Never heard of it before. But when I looked at all the hospitals that were involved, I said, whoa. So I got information from Boston Children's and from a bunch of Denver. So there's a lot of information to be had. You just have to ask. You have to know who to ask. And certainly the Pressure Ulcer Advisory Panel. You have included in your flash drive a list of the bibliography we use to do some of our research from this committee. And these are our task force members. It didn't show up on here, but one of the things that I wanted to say is that the work of this committee is not over. We have a draft that the ASET board will be reviewing and accept it. It's a guideline. It's not a definite standard, because all of you will have your own techniques and limitations. But that will be coming out. And the things that we will look at are, we're going to try to now focus on specific areas. What do you do with the patient that has psoriasis, eczema? How do you treat that? Abrading somebody that has a thick psoriasis on their scalp only causes blood. And then so now you're using a prep that is abrasive, and you're putting on a conductive paste, or you're using a salt gel. And so what does that actually do to the skin? So we're looking at that, and we'll look at how the pediatric and elderly population is affected, and certainly all of the critically ill patients. So that's it. That's all I have. We'll save questions until the end. Thank you.
Hey, everybody. I'm Brett, engineer, and great topics, fascinating. I am going to talk about a different side. To do this, and I'm going to go fast because we're about to run out of time. Oh, I've got a big yapper. Can anybody not hear me? Gotcha. I move around a lot. That's my good friend up there, Mike, who's helped me. I've had technical difficulties. And I'm going to wing some of this. Mike is just going to video it from up there for the folks that are joining us. ASET panel, right there. And what I'm going to do is I'm just going to show a lot of videos. Okay, I'm looking at this. I'm going to try to keep under 10 minutes. So we've talked about thermal. We've talked about chemical. We've talked about pressure, mechanical injury of skin. Fascinating stuff. But there's another area where I can play a little role in helping you understand, and it's all that electrical stuff out there. Those lights. We're sitting in a room with amazing antennas, and they are you. Our skin is God gave us an antenna, and it's called our skin. And this is one of the ways that it happens. It should be, is our speaker not? Let's see. Induce a voltage in the wires through inductive coupling. I'm going to start that again. Here is a demonstration of inductive coupling using simple magnets. Loose wires we monitor, and when we move the magnet near the wires, we induce a voltage in the wires through inductive coupling. There are three main parts of this big thing, electromagnetic coupling. Inductive coupling is one, you just saw it. This is not purely capacitive coupling, but it's not that far from it. Capacitive coupling using a simple transmitter from a cell phone, around 300 to 500 hertz. Loose pair lead wire monitored here. When we activate the transmitter on the cell phone, when it fires, you can see it's picked up in our wires. That is picked up through capacitive coupling from the transmitter through the air to the wires. Okay, so let's think about a couple of things. We just saw that our lead wires are what? They're like antennas, right? Think about the old television sets where you had the rabbit ears. What did you do to try to get a better signal? Oops, I'm sorry for getting away from this. You extend the rabbit ear, right? Every time you connect your lead wires to that patient, you're connecting a simple dipole antenna to your patient. And they do very good at picking up these electrical fields that are electromagnetic. Let's see. Now, to go back to this. We just saw inductive coupling. We're going to look at that. But this is that guy, the electrosurgical unit. So a lot of people will call it a Bovie. It's got a big return pad, large surface area, small current density, safe. The pencil tip has a tiny surface area, large current density. What does it do? It burns. MRI is another source of huge energy. The electrosurgical unit is a huge source of energy. Can it couple with our lead wires and create a burn? How about at both sides? Well, the answer is yes. What if the surgeon fires the ESU away from the patient's tissue? Can it couple with our lead wires and create a burn? And the answer is yes, and we're going to see that. Go back to some videos. This is a very simple
in this
ESU
case, when we activate the ESU away from the tissue, the subdermal needle gets a burn at its location. Even if we activate the ESU on the tissue at the same time that our subdermal is there, we will get a burn at the subdermal needle site because of capacitive coupling.
All that I had right here, ESU pencil or cable, right? Buzz, buzz. You know, cut, cautery, cautery. All I was doing was taping a lead wire. Taping a lead wire to the outside, and it was a subdermal needle. We never do this. It's a worst case, and you just saw that demonstrated, but it was very bad, right? Our needle became the new ESU pencil tip, right? Why does this happen?
Needle and tissue.
It's about surface area.
If we use tissue with skin, such as this chicken leg, and we embed the needle partially, but subdermally, just only on their skin, we activate the ESU,
Listen.
this will eventually burn. So
Listen.
here's
Did you hear it?
5 seconds, 10 seconds, and it is sitting there right now burning. You might be able to hear it popping. As I'm embedded, we can't get the
Sorry, I
arcing.
sped
Of
it
course,
up.
if we use just the tip, where the current density is very high, we can get arcing. Even if we start arcing and plunge it, the increased surface area of the metal in contact with tissue means that the
For the sake of time, I'm moving on. All because of electromagnetic coupling from this insulated cable through the air to the nearby subdermal needle cable. Does it matter would this happen under hydrogel?
can a hydrogel electrode have burns on tissue?
Obviously, the answer is yes. It's about surface area and about how much energy is being coupled electromagnetically. Does pairing needles does that make a difference?
When we activate the ESU away from tissue, we get burns at both needle sites. Even when we activate the ESU on tissue, we still can get burns at both subdermal needle sites.
In this situation, we think of twisting and pairing lead wires as decreasing artifact, and they do in our amplifiers. This is not a common mode rejected circuit. That energy is just looking to go home to that big surface area pad which is on the patient. Pairing needles does not help. I'm going to show you the most dangerous situation of all. I'm going to show you the situation where in this pan I have that well attached, let's just say this is our patient, this pan. You're about to see the situation where the ESU, large surface area return pad, is not connected to the patient. Very dangerous.
In this instance, when we fire the ESU pencil on the tissue, nothing, there's no electrical circuit. However, when we touch the subdermal needle to the tissue, we get a burn. Again, through capacitive coupling of the subdermal needle lead wire with the ESU return cord.
I just demonstrated the most scary situation. When you're in surgery and your patient does not have that ESU return pad well attached. I wish I had the time to talk a lot about MRI. The radio frequency pulse coils of MRI are much higher frequency than the electrosurgical unit, which means that they can capacitively couple a lot easier. We don't really have time. There is one other type of skin injury that I do want to discuss very briefly, and I'm going to shut up. When we have direct current, do we stimulate with direct current? Not really. We use pulses. Why? It's because of this. When we have a direct current, a battery, we have a positive and a negative. We can get an acidic buildup under the positive, under the anode, and an alkali buildup under the cathode. Very nasty. Electrochemical lesions. We don't want those. Why? Because in the goop known as our skin, we have ions. In the electrode, we have electrons that do the current flow. When we put those two together, we have electrons on one side, and we have ions on the other side. Various salts and water dissociate into hydroxyl and sodium and chloride and all these ions. When we put a battery and we've got a positive, do you think that some of those negative ions might want to go over because they're attracted to the positives? Do you think that some of the positives might want to go down to the negative and hang out? And that's exactly what happens. And Dr. Stecker so eloquently discussed yesterday morning about some of this reaction. Some of this bubbles out harmlessly and fairly neutral reactions, but we wind up with hydrochloric acid and sodium hydroxide. This is not a self-limiting reaction, and this one is a self-limiting reaction, but either case, we don't want them. I'm going to be quiet. I do have I can demonstrate these electrosurgical unit burns if anybody wants to see it, if we got time at the end. I'm going to have to.
And now I have 10 minutes, right? Here we go, right here. And I don't remember which one I am. Try that one. That's me. Thanks. Okay, so how I got involved with the interest in skin as it relates to what we do. By the way, what I'm going to talk to you about is basically my experience, okay? What we've done at All Children's Hospital in St. Pete. I was approached about, I would say, in 2012, because that's what it says on my slide, so I don't remember. So I was approached by our skin team that the hospital was developing a multidisciplinary, am I too loud or? A multidisciplinary task force to develop solutions to review the pressure ulcers we were having at our hospital. This included the neurodiagnostics team, which allowed me to have a better understanding to the complexity of the skin, some of the things that you've learned about, the things that can cause skin breakdown besides just putting the EEG electrodes on is your patients with poor perfusion, poor nutrition, poor hydration, those kinds of things. And you know, I didn't know all that when I first started on this task force. So as we developed, we said, well, how are we going to keep track? She said, keeping track is very important. So we developed some standards with our EMR, working with our IT department, and saying, okay, we need to document what we're doing. We need to document when we hook up the patients, when we check on the patients, and when we unhook the patients. What were the techniques that we used? What was the skin, what did the skin look like before we hooked up, and what did the skin look like after we were done? Any stage 2 or above had to have a drill down where we all met together to discuss that patient and see what we could be doing differently. And that included not only me and my staff, but with nursing and the skin team to see what can we do differently. So again, this has been over a couple-year period of time where we've been working very hard at this. So most, as I'm sure all of you know, most of our breakdown was coming from our frontal leads and our occipital leads, right? Because that's where we're getting the most pressure, either the patient's laying on their head or can't be moved, and or the frontal leads, again, with the tape when your head wrap. ICU patients are at higher risk for obvious reasons when we talked about nutrition and circulation. And we needed to make sure that we were assessing the skin more frequently. We were just putting the electrodes on and they weren't coming off again unless they had to go to MRI or CT until we were told to take them off. So what we started to do was, for our frontal leads, we started to include buffers, which we talked a little bit about here, where you put either a gauze underneath the tail of the electrodes, and I have some pictures I'll show you. What we've done at our hospital, and I know we've talked about foam, but we do use a foam that we got from our skin team, and this is something that you should really all get to know your skin team. If you haven't already been working with them, go and talk to them. Tell them this is something that you want to eliminate from your
your procedures, okay? So have a good relationship with your skin team. So we use a product called Mepalex, and again, it's a breathable foam that we use that goes under the tail of the electrodes. Because of cost and things like that, we use those on our patients that are at higher risk, like the ICU patients. So our policy is all ICU patients get that under their frontal leads or anywhere else we feel that is at risk. The other patients in the standard EMU get the gauze underneath their electrodes. So here's an example of the electrode, with the electrode with the gauze underneath. Then we talked about tearing and shearing of the skin. We noticed that some of the tape, we use a silk tape, but some of the people are very sensitive to that, and especially you can notice that mark that goes around where your tape, you can see almost exactly where your tape is at. So this is a special tape that we use on the frontal lead, and I think it's called Mepatac. Yeah? Yeah, and it sticks good, but not too good. And I need
Silicone. It's a silicone-based.
I need my drink real quick, sorry. So we use that. Sorry, I know I'm being taped. But you know, with all good things that you try, and this was a great thing that we did, we also started noticing, you know, you fix one thing and then you find another problem. So you have to be careful. See how there's a crease in the tape? We were starting to notice we were getting some marks on the head where the crease of the tape was. So make sure you put that tape on nice and flat, okay? So we talked about don't make the head wrap too tight. And do we need a head wrap? Just because that's the way we were always doing it, does that mean it's the way we should continue to do it? So we're assessing a little bit better on the types of patients that we really need head wrap for. Let's see, how am I doing? Okay, so cutting holes in the head wrap. So here's an example of we'll cut a hole in the head wrap where the frontal leads go so that it can relieve the pressure, okay? So if you notice our tape, pointing to my computer like you all can see it, the tape is underneath the electrode, okay? And then we still cut a hole over those frontal leads, again, to relieve the pressure. We do lay a little bit of tape on top of that because we have found that the electrodes will kind of sneak out of that little hole. So, and we also use a stockinette that goes over that head wrap. Again, you'll notice it's a breathable head wrap. So all of our ICU patients are looked at every day. That does not mean that we actually take the electrodes off, but what it means is we're gonna go in and we're gonna look at those patients. I've seen a lot of patients when we hook them up, their head is one size, and then the next day they've gotten lots of edema and other things like that. So unless you go into the room and really assess what that patient is looking like, you wanna make sure that you're making sure that nothing has changed with your head wrap. Hasn't moved, skewed, is causing more pressure on one area than the other. And just assess the general well-being of your patient. Every third day, our patients need to have their at least frontal leads removed and assessed, and if there is any problems, then they are moved away from that area to relieve the pressure. And we talked about, you know, well, what if something else is going on elsewhere? And it's important to just get to, you know, it's a lot of common sense, you know. Is this patient really not being able to move at all? So should I check the occipital leads, you know? So we already talked about that. So if any changes are occurring when we go to take those electrodes off, either at the third day or in general when we take the electrodes off, we're fortunate that our skin team is right across the hall from us, so we'll just go knock on their door, and they're very good about going and assessing that patient. Again, any patient that has a stage 1 or above gets kept track of, and all skins, again, 1 or above gets a safety report, because even though we're only reporting to the higher ups, 2 and above, we're learning a lot from, you know, the stage 1 pressure ulcers, and the key is to catch them before they become more than a stage 1. So the goal is to be able to recognize something before it becomes a stage 2. So our technologists chart daily on their checks during the hookup and during the unhook. We check if the skin is intact, and if not, who was notified and what was done about it. And I'm a big proponent of making sure that you look at the whole head because you don't want to be blamed for something later. So I always will say, well, you know, this was here before we started doing the EEG, because once they take it off, it's going to be all your fault, okay? And I want him to chart to make sure that proper procedure was followed. Again, if it's stage 2 or above, we have a huddle where we all get together and we discuss that patient with the nurse, the bedside nurse, the EEG technologist, and with the skin team to see, did we do everything we could? Did we follow protocol? If we didn't, why didn't we? And again, what are we learning from that? And that's how we've learned from making some of the changes that we've done. So as a result of these interventions, you know, the first year we sort of were just kind of trial and error. Then we came up with the charting and the EMU and some of the techniques that I've showed you. So in 2013 and 14 fiscal year, I had 7 stage 2 pressure ulcers out of 2,175 recording days. And the beginning of how are we going to track them? Is it number of patients? Is it number of days? So we just went with number of days because obviously if you're more number of days you're recording on that patient, the higher risk they are, okay? So then that was the year that we started, that was the year we were starting. So this last fiscal year that just ended, we had 3 stage 2 pressure ulcers out of 2,051 recording days. So we've decreased over 50%. Obviously our goal is 0, okay? So with some of the things that we're learning, or I'm learning on the task force, and from talking to people, I'm hoping we can get to that goal. Thank you. Ask questions, I guess, right?
Sure.
Yeah.
Yes.
Well, I have a question to ask you is about what you just demonstrated. What we can say if, as a IOM tech, if I'm inside a hall and just putting my EMG electrode, and if there is any connection with the EMG, my EMG electrode, with the BOVI, the ESU, is that gonna burn the patient like we just demonstrated, or how can you explain that a little bit? And also, if you have any literature to back up what you're about to say also.
Yes, to the last question, and I have hour-long lectures. I think there's webinars. I honestly, I don't know what, I've got so many things out there, I don't know what they all are. You bring up a very good question, and I didn't have the time to really summarize. One of the most important things you can do is to get to know the OR staff who are applying the ESU return pad. Watch them. Make sure it's well applied to the patient. That's really dangerous if it's not. Number 2, keep all of your lead wires off of your patient's skin. Our skin is very good at holding charge. Keeping the lead, even with a towel, if you can just keep those lead wires off your patient's skin by an inch and have a towel in between your patient's skin and the lead wire, it makes it much safer. Number 3, keep distance between the ESU cabling, not the pencil tip. Obviously, the surgeon's using that. It's very common for the OR staff to clip the ESU active pencil cable to the outside of the drape. I've got videos of this. You can email me. I think I've even got some of them online. Show them the video, and they'll go, oh, and then they'll never do it again. Keep the active pencil cable away from the patient's skin and away from your lead wires.
That's it. And this case that there are so many of us, I might think I might be one of them, I don't even know. I was not, that's the first time I heard that you just said or what you just said. That means I might burn some patients, I don't know, because I met a few friends of mine, or when we're talking about skin burn like that, they said, I heard something about that, but that never happened to me. But this that can happen to me or somebody else, but we don't know about it.
It's all new. Dr. Stecker, Dr. Patterson, and I wrote a set of articles 2006, 2007. I've just started doing videos in the past few years that really demonstrate it, and I need to publish some stuff on it. It's a huge danger.
Using blunted needle tips, how are you ensuring good impedance and technical integrity throughout, 24, 48 hours?
The question is, if we're not using blunted needle tips, how are we ensuring that we have good impedance integrity throughout the 24 to 48-hour recording? So the one thing that we are looking at, and I didn't say this when I spoke, is that the question of what the impedances should be over the duration of recording. And actually, the task force is now doing a little mini study to see how many people that are doing long-term monitoring are using impedances under 10,000 ohms. And I think the question is, as long as impedances are equal, but under 10,000 ohms, you maintain integrity. If it is not, if you don't maintain integrity for whatever reason, then I think the electrode needs to be removed and reapplied. I have difficulty with the blunted tip because not everybody is not touching skin. And when you scratch that skin, the reason is you want to punctate that skin a little bit so that you have whatever fluid, and Carol could probably address this better, come to the surface. That's what's going to reduce your impedance. And then you're going to put this salt gel, conductive paste. Although there are other conductive creams that are not the salt-based gels that we had used for so many years. So that's what we've been doing.
Two quick questions. I'm sorry. I'm over here. This will take a second. By chance, has there been any comparison data using the cap as compared to collodion glue down for these LTMs? And secondly, how far does that tip on the ESU have to be away from the needles to cause effect?
I wasn't,
I don't know who that was. Go ahead.
We don't use caps, so I can't speak to caps. So the question was, I'm sorry, can you repeat the question?
In the comparison data, there's an advantage to using the caps for LTMs compared to electrode placement.
I don't have any experience with caps. Because I do kids and everybody's head is so different, I don't have any experience with caps, so I can't speak to caps. Yeah.
I don't have any experience with using caps either, but I think, just in theory, when you think about it, I think you have to work a little bit harder with a cap to be able to get to the skin surface. And if that means, I don't know what you're using to be able to be sure the hair is away so that you get to skin, it may be a cause and effect at some point. I don't know, though. I don't use them.
Comment here, one with a lot of experience with EEG caps and actually, and I cannot speak on behalf of all cap manufacturers, but there are caps in the market where you can apply the cap, get below 10K impedance without the need for any skin abrasion. Actually, the gel that we are using with our product is more abrasive compound and work. Now, I would like actually somebody to evaluate the long-term effect of these caps and what they are used for, more than a day or two, because you get the rubber cups and there is pressure and that would be interesting, but no skin abrasion one.
Just one comment, and thank you for your comment and suggestion. If anybody has a particular question or area that they would like to be looked at, I think that should be directed to the Skin Safety Task Force so that we can, as we move forward, look at some of these things. Our work has just begun, and so we have addressed some issues. And it's right now, I think the committee is the consensus of the committee is it's about technique, and we just have to retrain our brains. I'm doing this 50 years, and believe me, when impedances are 5.7, I'm going crazy because it has to be under 5K. So it's just retraining and rethinking.
In the interest of time, I think that we need to, I think that you said what needed to be said. This is going to be just the beginning. We're going to need to continue to look at this, and in the interest of trying to make travel schedules and everything, I think we're going to need to adjourn. I have to be the bad guy. At this point, I'd like to thank you all for your presentations. Thank you so much. And I'd like to call to the podium Cheryl Plummer, President ASET. Thank you.
I'll make this very brief. I'd like to thank each and every one of you for coming and attending the ASET 2015 annual meeting. I hope you enjoyed it, the conference, all the activities here at the Bonaventure. I hope that you will go back home with a renewed interest and enthusiasm, and I hope you take some new things back to your labs to try. Please remember that we are here for you. This is your organization, and you just need to reach out if you need things. The ASET staff is wonderful. They're very responsive. I've called on them through the years for many, many things. They do get back to you. So please reach out. Remember, there's a lot of resources available online. The journal now is online, so that's all very interesting, and you should take advantage. Also, not to sound like a broken record, but please consider being a clinical site in the future. It's important for us to know how you feel about your experience here. So please fill out your evaluations, send an email, just let us know what you liked, what you didn't like, what you want to see. That would be important in the future. We've already talked about the app. You all seem to like that. We'll probably do that again. Our 2016 ASET meeting is going to be in Pittsburgh, which is my hometown. So we're just going to show a brief clip of what you have to look forward to. If you'll just give me a second, you'll see what a beautiful city it is, very walkable. So, if you saw during that movie that the fountain that kept showing up, that fountain is directly in front of the hotel where the meeting's gonna be held. It's in Point State Park, which is actually a state park where the three rivers come together. So it's the Monongahela and the Allegheny joined to make the Ohio. So it's pretty cool. And I can't wait. So I guarantee you, if you come, you'll have a great time. I'm gonna see if the pirates are in town, try and, we'll get all that ironed out. So I hope I see you all there. And now, if you would stand up and look under your seat, there'll be an envelope attached to one seat. Hopefully that person didn't leave. And if you did, you get a 2016 annual conference registration. And Dr. Milan's laptop is at the desk. You got it? Awesome. Yay. Well, safe travels, everyone, and I enjoyed meeting many of you, and I hope to meet the rest. Those go to the desk.